also makes a little bit of sense to me in my brain that if you're blocking this off, I want to, as soon as possible, so it sounds like it's a medical emergency when they come to the hospital. Yes? It is. I've been waiting in the ER for 4 hours. It doesn't matter. They come in there, who do you see first? Who's gonna die first? Them. They're gonna come to the front of the line every single time. Because they don't have very much time to live, right? Because if blood's being blocked from coming here, look at all of that is fed. You see that? Or if you look down here, flip it around. If you have blockage, I think it was on the other side. Oh my God, let's say you have blockage there. What happens if you have blockage at the circumvent? I think this is what they call the widowmaker, folks. That's a person who'll be grocery shopping, no matter how healthy they are, they will fall out. Done. Done. If you don't get them to the cath lab right away, CPR, cath lab, that's it. Bye-bye. That happened to one of my coworkers a couple of years ago. He was fit military. Fell out right in the middle of aisle 4, man. It was very, very unexpected.
And why did that happen? Could you repeat?
Why did what happen?
Like, I mean, just randomly at that one.
Even though he was super fit, yeah, it just depends on like if you have a kidney stone, it just maybe sometimes they're small enough they can pass through, sometimes they're too large and they get lodged. It's random. It's not like it's something that like you have to, it's a formula. It's not a formula. All I know is though, if you get an embolism, and it could be really, doesn't have to just be plaque. You could break a long bone, and your long bones, if you remember from A&P, have a yellow marrow, which is fat. So you break your femur, you're at huge risk for fat embolism. All right? Somebody breaks their IV off in their arm. The tip of that travels through. That's an embolism. You accidentally don't get rid of all the air at the bottom of that patient's IV bag, and you're pushing it through high pressure, and at the very end of that is air, and you put about 20 milliliters of air into your patient. That's an air embolism. All those things will kill your patient. Embolisms are bad. Are we good? Okay. All right. Oh, while I'm still on this, I want to teach y'all real quick about Mona. 911. Mona. All right. Do you think these people are going to have pain? If you ever let your foot fall asleep, or maybe your hand fell asleep, one of your limbs have fallen asleep before, do you know why they've fallen asleep? Quick answer. It's because you cut off circulation. So that pain is a sign that something's wrong. And your body was saying, hey, we don't have oxygen. Get off of this. Extend this. And when you do, that numbness and tingling starts to go away. And it is painful, right? So that's the same thing that happens here. This heart muscle sends the same signal through the nerves. Hey, it's the same pain. It's just located here. It's the exact same thing. Hey, you're cutting off circulation to us. We need you to open us up real quick. If you open it up, the pain is relieved. If you do not, the pain does not go away. That's what we're talking about, that unstable angina. So when they come in, we give them morphine for 2 reasons. Yes, it helps with their chest pain. But what does morphine do to the blood vessels? Say it out loud. It dilates them. Do you want your blood vessels dilated? Dilate. In this situation, absolutely. I sure do. I sure do. So that's one. Pain relief, and it dilates. What else? Oxygen. I'm going to give my patient oxygen. Why am I going to give them oxygen? But Ms. Johnson, their oxygen says that they're 98% on room air. I don't want to give them oxygen. All right, I'm going to teach y'all a lesson. Yes, you can kill someone from giving them too much oxygen. But if they have proven to have a blocked artery and decreased tissue perfusion, why not maximize on the oxygen that is being delivered to their tissues? Just put them on some oxygen. Can we do that? Please? Give them oxygen, okay? It increases available O2. Mona, baby. Mona, Mona, Mona. What's N? What do you think N is?
Nitro.
Yeah. What's nitro do? It also dilates the vessels, but it's a very powerful venodilator. Okay? And so it's going to definitely make sure that it dilates the vessels in the heart, not just the arteries, all of these vessels here. Okay? So we know it's going to dilate these coronary muscle vessels. And what's this one? ASA. Acetylsalicylic acid. Aspirin. Aspirin makes platelets slippery. It decreases platelet aggregation. So y'all not gonna be able to stick and form. Is it gonna prevent what's already there, stop what's already there? No, it's not a clot buster. Only a thrombolytic can do that. But it's gonna prevent new ones from forming. It makes them like literally like it's on a slip and slide with dish soap. And that's what we want. So is this all I have to do? I just do Mona and they're done? No, because I still got a clot there, or I have some sort of an occlusion from something. So this patient still has to go to what's called the cath lab. And for the rest of this, all you have to do is listen. When they go to the cath lab, depending on what's going on, they may have to go in there and open up the blood vessels. If they have a total blockage or if they have damage, they may have to take a vessel from one of their leg veins, and they may have to do what's called a coronary artery bypass graft or a cabbage. These are things y'all will hear about later. And that just allows there to be a connection from wherever the blockage was around it and gets it to that tissue.
Could they just vacuum it out if you just had a clot?
Okay.
Or is it too, are the
So,
tissues too delicate to do
those
that?
are really, really delicate. What you're thinking of is like an endarterectomy. We do that mainly with carotids, and it is very dangerous. Like even with that, and as large of a vessel as that is, some bad stuff can happen. Some bad things can happen with that. So their bigger thing is what they have to do is look at what's going on. They could just put a little tiny little stent thing in there and just open it up. They do have situations where they can do thrombolytics and totally split the clot. It really depends on the situation. But you don't really see them routinely going in and extracting clots. Not one that's gone that far down. Doesn't mean they can't do it. And who knows with technology, it's maybe already be happening at someone's hospital.
We have a mesh that sits, what is it, tricuspid valve, you know, right next to it where it's got the little like dip, so they've got that little mesh thing that sits in there, so that like blood can't pool in that now too.
That's good.
Yeah.
That helps with all those different types of, whoosh, whoosh, you know what I'm talking about, murmurs.
Yeah.
Do they do to get a place for MIs and strokes?
Yes. They're finding it's just a very effective med. I had a patient who was a nurse ask me some questions I just didn't know the answer to. I had to look it up. It's pretty interesting. Pretty interesting. So Mona makes sense, does it not? Getting them to the ER, to the cath lab ASAP makes sense. When they come to the door to cath lab in less than 60, to me that even sounds like a long time. Get them in there ASAP. And then you'll at least have the information for that mother who's wondering why her child has been waiting there for 4 hours is still being pushed to the bottom of the list. Without saying they're more important than you, ma'am. You'll figure it out. You at least have the info to get started with that.
We have to get our EKGs within 10 minutes of chest rate.
Good. Good stuff. All right, you guys understand the layers of the heart. Biggest thing that you don't want to do, this is the actual muscle that is around the heart. It's kind of like if you think of a saran wrap around the meat package from the grocery store, that's your pericardium around your heart, okay? What you don't want is for that to have fluid around it, because if you have fluid around that pericardium, what can the heart not do? It can't beat, right? So in that case, you have other things that end up happening. I won't talk about it in this class, but you definitely don't want that, okay? You don't want this thing to get too thick, because we've got something called Starling's Law. You take a rubber band, the way a rubber band is at first, you play with it a little bit, fine, but if you stretch it out, it's not gonna go have that same stretch or that same oomph that it had before if you stretch it too far. We can do that with our heart muscle. That's why cardiomegaly is a problem. I think people think cardiomegaly, it's gonna go back. It's not. Stretched out like a uterus with triplets. It's done, okay? It's not gonna bounce back. Are you guys with me? So you don't ever wanna have a boggy heart. And that can happen if you have too much fluid accumulating, which can happen with my heart failures. Got it? Endocardium, endo means within. The endocardium is the part of the heart that comes in actual contact with the blood. So the myo is the muscle, it should be reviewed from A&P. Peri, that's that tissue that surrounds this, but the endo is the part that's within. You go to the dentist, and you have some junk going on in your mouth, they're gonna end up putting you on a prophylactic antibiotic. Some of this may sound familiar. Why are they doing that? Because as they're playing in your mouth, stuff can break off, get into your bloodstream, get into your heart, and touch the endo, okay? The endocardium, the part that comes in contact with the blood and this muscle, right? And what happens is that bacteria can sit there, camp out, and grow vegetation. And then you let that vegetation grow, and then the heart pumps. Now you got plaque that's floating through your bloodstream. Can you get an MI from that?
Yes.
Can you get a stroke from that? Yeah.
That also lead to endocarditis.
That is what causes it, for sure. That and IV drug use and some other things. Bacteria sit in your bloodstream for too long. Absolutely. Absolutely. Yes, yes, yes. All right, y'all already know all this. You know this. What they're trying to show here, that one is that's a little pericardial window they'd have to do if there's too much fluid around the heart. You already know all that. This is not an A&P class. You just need to know the A&P for it to make sense. You already know this. They look like a bunch of words, but you know it. That's literally what Anthony said. Look at it. Just look. It just looks like a whole bunch of intimidating words, but you know it. Exciting, huh? Literally the same thing. Pretty cool, huh? All right. So what we talked about is the flow from 1 and 2 cardiac cycle. The last part you all want to talk about is your blood pressure. You guys have heard of systolic and diastolic, haven't you?
Mm-hmm.
For a long time. Do any of y'all have any idea what any of that means? Be real. It's the time to be real. Because if you're real, I can teach you something. You don't know, do you? You looked it up?
Yeah, in a couple of different classes. I think when we first had Dr. Beasley, blood pressure.
What is, can you tell me maybe in layman's what any of this means? She giving a look.
How much
No.
Go ahead,
force
Fran.
systolic is, how much force is pushed on the walls of the vessel when the heart pumps, and diastolic is when it relaxes. So how much pressure when it's returning.
Okay.
I was trying to put it in my term.
Can you please make it easier?
What if I'm a 5-year-old? Can you explain it to me? Because I'm a patient. I ain't getting nothing you just told me.
Can you just say the love and the dove of your heart?
The what?
The love and the dove of your
But a patient doesn't know what I have a lub and a dub in my heart now.
Well, that sounds like the
Squeezes.
5-year-old terms.
How much pressure?
Well, then maybe I'm a 25-year-old man because
Oh,
I don't know
okay.
what a lub and a dub is.
Okay.
I want y'all to know it well enough that you can talk to doctors, nurse practitioners, your peers, but you can also put it in a way your patient can understand it. And when you really get something, you can do that. Okay? All right. Stand up. This is the only time you're going to hear me call it this. I will never say this again after this. Because it's a pet peeve. You stood up just now? Sit down. Stand back up. This one, top number. You'll never hear me say that again. And you'll never say that unless you're talking to your patient. We're too sophisticated to be calling them top numbers and bottom numbers. Okay? The top number is systole. Systole is also known as, and this should sound familiar to you, afterload. It doesn't mean you know it, doesn't mean you understand it, but you've heard it before. I know you have. It's in your curriculum because it's been in classes that you've already taken that I taught. Afterload, but that, so they're the same thing. Systole, top number, is also known as afterload. Diastole, bottom number, is also known as, yeah, you've heard it before. You didn't get it, but you will. Okay? Alright. So you guys are gonna represent my left ventricle. What's in the left ventricle? Oxygenated blood that's getting ready to go where? To the body. It's pretty important, okay? All right, and you know where you're coming from. From before the lung, after the lungs. Left atrium, okay? So that's where you came from. You're in the left ventricle and you're ready to go to the body, okay? Guess what? This leads to the body right here. So what vessel would this be?
Aorta.
This is my aorta, okay? And this is the door that leads to the aorta. So what is this? It's the aortic valve, okay? So the aortic valve, this whole thing here, this diameter represents the diameter of my aorta, the vessel. Are you guys feeling me? It represents the diameter. If I decrease the diameter, I am decreasing it, aren't I?
Mm-hmm.
Okay? This is what it's gonna look like. If I increase the diameter, this is what it's going to look like. Does that make sense? Are you still tracking? Okay. If I have the diameter of my aorta look like this, let's start with this. This would translate to a blood pressure of 90/60. Got it? Systolic, 90. If I do this, it's about 110, 120, 130, 160. Yeah? See how your eyes are going up? 200. As I decrease the diameter, I'm causing vasoconstriction, yes? But I'm also causing my systolic pressure to go up. Does that make sense? How does that translate to afterload? How does that translate to the work that the heart has to pump against? Well, I'll tell you. If this is, you wanna come in and be preload? Okay. So if this is afterload, this is the diameter. Can y'all show me what it would be like for you to get out? Come on, try. I want you to actually attempt. Line up. Because your drops of blood trying to get out to the body. Where is everybody? Oh my God. You gotta work really hard to get out. Do you not? Okay, go back a little bit.
Unless you got big balloons.
Go back. Alright, you gave somebody a beta blocker. Their systolic pressure is dropped. Try to come out. Come on, come on, come on, come on, come on. Move, move, move. Hey,
Yep.
move.
That's lovely.
Know that. Alright? Y'all didn't have to work so hard to get out, did you? I noticed you didn't even get up. You're the vegetation. Come on.
I'm Clyde.
She's a Clyde. You're literally, I'm
Clyde.
she's vegetation, man. You gotta move. All
You
right.
don't want me to move.
So-
Block up with that.
Do you see how hard it was to move out when my blood pressure was higher? When my afterload was increased? Yes? That's the same thing. The systolic pressure and the afterload, look at the board, are the same thing. If you increase it, what ends up happening is you gotta work harder to maintain that cardiac output, right? However, if I have an increased systolic pressure or increased afterload, right? 100 to 190, that's an increase, is it not? Increased afterload. If I have an increased afterload, what ends up happening to the blood that's in my ventricle? It backs up. That's what causes increased pressure. Because volume translates to pressure. So when this number was lower, y'all were able to get out. My ejection fraction was good. My cardiac output was good. My diastolic pressure was fine. But as soon as I started closing this door, y'all backed up. And you backed up. So an increase in afterload is going to cause eventually an increase in breathing. And consequently, a decreased cardiac output. Then this type of blood pressure, not only is it going to cause a stroke, because that's when people say, oh my God, the blood pressure is 210 over something, you're going to stroke out. You know why you're stroking out? Because there's no blood coming out to the aorta going to the body. So you're going to have what type of stroke? Is it a hemorrhagic stroke? It's an ischemic stroke, because there's nothing going out. Does that make sense? But this is also going to cause this patient to have blood that backs up, and goes to wherever it came from. Do you understand the systolic pressure now? It's nothing more than the diameter of your blood vessel, mainly the aorta. That's what we care about the most. That's what that is. So the lower your systolic pressure, that's the wider the diameter, meaning the less your heart has to work against. And the higher this number, the higher the systolic number is, that's the higher the afterload. That's the harder. That's a high afterload right there. That's probably like 210 right there. Does that make sense? So when people have high blood pressures like that, there's some circumstances where they want the patient's blood pressure to be high, and we'll talk about it. But when it's high like that, you gotta get that open, or else your patient's not going to get cardiac output, meaning they're not gonna perfuse, meaning they're at risk for MI, they're at risk for, and that would be an ischemic MI, right? Not from a clot, or they're at risk for an ischemic stroke, or just shock. And shock is due to a lack of blood flow to the tissues. You see how it all starts with the matter of the heart? So, when they talk about systole versus diastole, they put it real simple in contraction relaxation, but that doesn't really help you understand what's really going on with the heart. That's what that is.
So, I got a question.
Yep.
So, if your systolic is somewhere around regular and your diastolic
120?
Yeah, and your diastolic is rising,
Yeah.
what kind of correlation, like, what, because a lot of times we don't even look at the diastolic. I'm more worried about systolic than diastolic.
Right, but I can tell you.
But I also have seen the 130 over 90, or 100.
Yeah, 90 is not that big of a deal, but if I have 90 and then it's creeping up to 100 and that pulse pressure is narrowing, that top number is not increasing.
Yeah.
I'm not saying that after today. Right? Systolic is not increasing, but the diastolic is increasing. That we call it the pulse pressure is getting narrow. Usually what that just means is my aorta, the diameter is it's open enough for you to get through. That tells me it's probably a pump issue.
Okay.
Either a valve, maybe you've got valves that are, a murmur, stuff that's pushing back, right? Regurg, mitral regurg,
Okay.
right? Aortic regurg, or you may be dealing with,
Not to worry about it. Why not? Like,
yeah,
where's my why?
especially if it keeps increasing.
Yeah.
Yeah. In that case, I would want to watch the oxygenation to see what's going on ahead of the game.
Can the size of the chambers affect it as well?
Yes?
Like a narrowing of a ventricle or.
Well, that could be it. A narrowed left ventricle could do that, but you don't usually have a narrowing unless there's something that's blocking it or obstructing it. Does that make sense? If anything, it stays the way that it is or it gets bigger because of vascular congestion. Okay. These are really good questions, and I can tell you're really critically thinking. Some of y'all, it's too much for your brain, but I'm not testing you on it. It's okay. I am testing you on cardiac, but a lot of the stuff, the angles they're taking it to, I'm not. Okay? If you need to take a break, take a break. I'm here because I need y'all to get this info. You guys understand action potentials, yes? Polarization, depolarization, repolarization. Are we good with that? Same thing for the heartbeat. Same exact thing. And I think I kind of alluded to that and drew it on the board. I know we've been closing this door, but I feel like I'm going to pass out. So, in order for me to teach the way I teach, we're just going to have to let them hear Miss J talk. I'm sorry. All right. They need to fix the air setups around here. I just need air and projectors. That's it. Okay. I don't care as much about rapid, early, late, all that. I just care about resting membrane potential, which is negative, depolarization, repolarization, 3 phases. Understood? Are you with me? Okay. Now, you have the atria that need to depolarize. You have the ventricles that need to depolarize. You have the atria that needs to repolarize, and you have the ventricles that need to repolarize. That is literally your EKG tracing. Got it? That's it. That's it. Okay? So, and then, do you know your alphabet?
Yes.
Yeah, you do. So P, Q, R, S, T. You may have a U in there too, depending on if you got something wrong with you. It's usually a sign of an old heart attack. And it looks like that. It's a U wave. So, P wave, what do you think that is? The first thing? I say atrial what? Depolarization. So your SA node fires. Your atria depolarize. Does your heart beat? Not necessarily. Hopefully, but not necessarily. Okay? Then from here, that was the SA node. Then we have a node that's in between the atria and the ventricle. Guess what it's called? Atrioventricular node. It's pretty easy. That's actually your plan B though. Because remember, SA was 60 to 100. Plan B is never as good as plan A, is it? No? This one is 40 to, it's not, let's be real. It's 40 to 60. So it's a backup pacemaker. But if that's what's pacing your heart rate's gonna be slower. So the atria depolarize, and then what happens is that impulse travels all the way through to down to by through the bundle of his, through the left and right Purkinje fibers, and the hope then, now it's spreading through the QRS, the hope is that we have ventricular, what do you think is going on here? It's a huge wave. If that was atrial depolarization, what do you think this big wave is? Ventricular depolarization. So this one is A depolarization, A depol. This one is vent. Y'all, I'm just abbreviating. Now, whenever you drop a big old rock in a pond, which wave is the biggest? The first one, yes? The after waves are going to be smaller. So I have a big old wave. What do you think that one is? It still has to do with the ventricle.
Ventricle repolarization.
Thank you. So this is your ventricular repolarization. This is when the happy person goes away and they go negative again. So depolarization, repolarization. But my question is, you didn't say anything about atrial repolarization. Why didn't I say anything about it? Well, let's march it out. You don't know. If this is ventricular
R is the start of ventricular depolarization.
Q. QRS goes together.
Is all okay.
Yep, it's P, QRS, T.
Okay, I thought the Q was your plan B.
No. My AV node,
Mm-hmm.
which is right inside of here, that's my backup pacemaker. The SA node fires, and that's what causes atrial depolarization. Then it has to go past the AV node, which is fine. But if this doesn't work, the AV node steps up, but it's only gonna do it 40 to 60 times a minute. Okay? I was just talking about the pacemakers here. But let's say the AV is just flowing through it. It's not the pacemaker. Your SA's firing fine. SA node fires, and if you they have animations on these. I'm just trying my best to illustrate this, but that's why they do actual animations for this, and you can see it as it goes through. For my visual kinesthetics, they're beautiful. Okay? So atrial depolarization here, ventricular depolarization here, ventricular repolarization. Well, if this is ventricular depolarization and repolarization, where do you think atrial repolarization is occurring? That's depolarization. Where do you think repolarization is occurring?
In the T and the U.
It's going on during the QRS, but why won't I see it? Because it's going to be overshadowed by that gigantic QRS. Because if this is my first wave, that baby wave is probably that small, you'll never see it. I say that because I always have a student say, okay, I see vent depol, I see vent repol, I see atrial depolarization, but I never see that the atria are repolarized. How come I never see it? It's not necessarily common sense or critical thinking, it's nurse's sense. That's why. It happens, you'll just never see it. Does that make sense? Y'all following me? I know it's a lot, but this is nursing, this is cardiac. It makes it harder too when I have to go back and teach the A&P of it. All right. This is everything I just said. Now that repolarization of Purkinje fibers, again, the only time you usually have, well, the U wave tends to happen at the end after the T, but nobody looks at that. What we do look at though is if you have a Q wave by itself, that's usually a sign that you have an old heart attack. Like you had one. There are times where people are like, I never had one. I found that my grandma had one. They sent me an EKG and she had a nice little Q wave. Oh, like, Grandma, you've had a heart attack before. Sorry to break the news to you. Okay. So as you can see here, that's the Q wave, but when it's indicative of an old MI, it's marked. Like it comes down almost as much as that S wave does. You see it on the picture here? Okay. So again, these are just the structures. SA node, that's plan A. AV node, that's plan B. Bundle of His. Left bundle branch, Purkinje fibers. I don't test y'all on this. I'm trying to think of what class has this. I know that y'all went over that in Pharm. I don't know what y'all's PowerPoints look like, but I had it on mine. I think it was pretty standard. So it probably is not the first time you see this, but this, you've heard me talk a lot about cardiac output. This is the formula to get it. It's the stroke volume, why we want that DIG, times the heart rate to equal the cardiac output. And we want to have about 4 to 6 liters of blood every single minute. So if my heart rate goes up, in order to maintain the same cardiac output, my stroke volume is going to decrease, and vice versa. Because it's an equation. Does that make sense? An increase in one is going to cause a decrease in the other. That's the reason why with DIG, it'll increase my stroke volume, but what's it going to do to my heart rate? It's going to drop it. That's why I'm going to count it for how long? 1 full minute. All right. The rest of this stuff is all you already know. I know you already know. Okay, So there, you guys understand hypertension, don't you? All you have to do is make sure you get it already by now. I know you do. You should already know all these signs. The only thing I want you to know though is the classification. Because as you know, in every single class, the classification is going to change. It'll be 130 in one class, 139 in another. Because these are the textbooks that we're testing from, this is what I want you guys to look at. That what pre-hypertension is and hypertension. Stage 1, stage 2. I promise you it'll change by the next class. Not my rules. And you already know, why am I even talking about hypertension? Why do I care about this? Why am I making you learn?
It could lead to an MI or a stroke.
Yeah, pretty important, right? Yeah, and it really can do a lot of other things as well. So remember we talked before, you got salty people, sweet people. Salty people struggle from this. Because you crave salt, it's usually cultural. You crave that, but where that salt goes, that water goes, the pressure goes. Smoking also places people at risk for embolism development, so you got that. You heard me talk about shock. When we were talking about perfusion and oxygen and blood delivery to your tissues, this is what shock is here. It's literally when you're not able to get the blood to the tissues. There's different reasons behind the shock, but shock is shock, period. It just means your tissues are not getting the blood flow that they need. So if the heart is the reason for it, like the heart is not, because of heart failure, if the heart's not pumping that blood the way that it needs to, you will go into what's called cardiogenic shock. Make sense? If you sever your femoral artery, your heart has nothing to do with it. You're bleeding out at this point. You're losing the actual blood that your tissues need. So if you cannot get that blood and tissues to the blood to your tissues because you've severed your femoral artery, that's because of hypovolemic shock. You just don't have enough volume to get the blood there. Does that make sense? Okay. We talked about sepsis. Remember I said you have 3 phases. First phase, you catch it early enough, you can recover. No problem. Second phase is where stuff starts to get a little tricky. This is when, and you'll learn more about shock in detail, but this is when my body starts responding. I start having massive, widespread vasodilation. Remember, when I vasodilate, what happens to my pressure, guys? It drops, right? I decrease that afterload, everything drops, but that happens in my entire body. So if my pressure drops, you can see how that can cause an issue with me getting blood to my tissues. The other issue with septic shock, remember we talked, I may have the oxygen, but if I've got too much junk going on, septic, my tissues may have the oxygen, but they're so messed up that they can't even accept it or pick it up. So septic shock does some serious damage. Never let somebody sit with bacteria in their bloodstream too long. Urosepsis, those UTIs, man, like all of that, big time. They need to get it taken care of. If your brain, your parasympathetic and sympathetic, start doing some wild stuff, and they cause your blood pressure to go up, go down, heart rate to go up, go down. If your blood pressure drops, blood doesn't make it to the tissues, that's shock. But the source of it has nothing to do with your heart pumping or not. It has nothing to do with you exsanguinating and severing an artery. It has nothing to do with bacteria. It's because your brain and your spinal cord are doing some wild stuff. Does that make sense? It's not regulating your blood pressure right. So because of that, we call that neurogenic shock. If you remove all of those other factors out of the way and you get stung by a bee, you're allergic to bees. Remember what we talked about, what happens with sepsis? It's the same thing, that inflammatory immune response. You get stung by a bee, your whole body is freaking out right now. It goes into, if we think all the way back to the beginning, widespread vasodilation as a result of the whole immune response, okay? That's going to lead to an inability to get my blood to my tissues. So that would be from anaphylaxis. So shock is shock. If you just understand shock, all you have to do is assign it to the different reasoning. So if I say you're taking care of a patient who was stung by a bee and they have allergies, which of the following things would you be most concerned about? That, okay? If I could easily take that up a notch too and spin the question a little differently, it's gonna require that you understand shock and that you can identify the different ways. So I think I have a question that has matching, even though matching's not really NCLEX. It just allows for you to be able to get those questions without having 6 or 7 and potentially getting them wrong. So you definitely gotta know them. All right? And you have to know what these people look like. I don't want you to memorize it. Imagine someone's blood pressure dropping. Imagine their tissues not getting enough oxygen. If you didn't get enough oxygen, how would you present? One thing they don't even have on there is confusion. Yeah, they do. Decreased mental function. You don't think you're going to be confused? You walk into your patient's room and they're starting to take their gown off and pull all their leads off. Check their oxygen. Bet you it's in the 80s. And they start plucking. Yeah, you would too, wouldn't you? Because your brain is an oxygen hog. So I want you guys to be able to think through these things and try to imagine what your patient's going to look like. Then you won't have to memorize it. Does it make sense that the arterial blood pressure will be down? Yeah. With shock? Does it make sense that they'll have cool, clammy extremities? Yeah, because what brings heat and warmth? Yeah. So you lose the blood to your extremities. How would you be warm and dry? Make sense? Or red? You wouldn't have that. So that's what I'm saying. This is how I want y'all to think. You're going to be the opposite. You're going to be pale, maybe blue. Why am I having a decreased urine output? Why? My body's trying to retain fluid. Yeah, all of those different cascades, ADH, right, against diuretic hormone. I don't want you to pee anymore. I don't want to lose any more fluid because we're already losing fluid. Yeah, exactly. Your kidneys are going to be the first organ that snitch on your body and tell you that your blood pressure is low. First one. That's why we look at the map. The map is the number in the parentheses, right? Because that number, the mean arterial pressure, tells us that our organs are perfusing. Okay. So, to your question back there, madam, you were asking, which one do we look at, systolic, diastolic? You look at both.
Yeah.
But at the end of the day, if you're concerned about low blood pressure, you're going to look at that map. Make sense?
Yeah.
All right, let me see if there's anything else on here. Y'all good with MI, yes? Yes, you are. No, it's a lot. I'm gonna have to do a narrated on respiratory because y'all's brains can't handle it.
Yes, please.
And do y'all understand heart failure at this point?
Yes.
You do, don't ya? This puts everything that we talked about on the board in a different type of cascade. Some people's brains may work better with this one, okay? And how am I gonna diagnose it? This makes perfect sense, doesn't it? All right, I'm gonna see how that patient looks. And my goal is going to be to try to correct the cause, but if it's actually failed, it's failed. They're gonna be on medications for as long as they're able to live. You just wanna improve their quality of life. My grandpa lived from 35 to 72 or 75 with heart failure. He quit everything, smoking, drinking, took his meds, he didn't play around. Sound like your family member, didn't play around, didn't play the radio. But when it was time at the end, he was in the hospital every other month. It was time. But that's a good run, right? 40, how many years is that? 3, 4, 5, 6, 7? That's a long time. All right. And then you need to know, we already know this here. Stroke. Y'all got stroke because of how we learned the information. Did you not? And you remember from pharm now the medications that you give to get rid of an actual thrombosis. You need a thrombolytic. We'll give heparin to prevent new ones from forming. And Coumadin they take at home. But I'm giving TPA or TNK to get rid of it. It's a thrombolytic. I'm going to split that clot. Does that make sense? That's only if I have a clot. If I'm bleeding, do I give those two things?
No.
Okay, not unless you want them to bleed out. Okay. All right. I think you guys got this. This would make sense. Just read it. I'll do a narrated on respiratory. It's just not happening. I think this is the last one. DIC. Let me see. Yeah, I gotta teach you on DIC real quick, and I'm done. I promise you'll handle it. DIC you're gonna see more often in OB settings. I wouldn't be surprised if you've seen it many times. Maybe you don't know. Having babies is extremely dangerous. These people don't understand what's happening. Seriously. Any of the conditions, especially when I send the respiratory one, the one I'm gonna focus on a lot is ARDS. Any of the respiratory conditions, any sort of major damage to your body can cause DIC, but pregnancy just wreaks shop on your body. And there's no rhyme or reason. We just know that certain conditions predispose people, but we can't guesstimate it. We can't say you look like in a day you're gonna go into DIC. There's no way to know. So what DIC is, if we think about in order to make a clot, you need a brick, which this represents my platelet, right? So you need bricks and you need what else? You need my clotting factors. We got that already, did we not? We got that lesson, okay? You need both, this plus that. If I just have this, I kick it over, they're just a bunch of rocks. If I just have this, it's just mortar. These two together are required. So what happens is pretty wild. In DIC, out of nowhere, some switch goes off and all of the clotting factors in your entire body are used up. So imagine now somebody coming in and saying, all right, we're taking all the mortar. We're gonna use mortar on pebbles, mortar on this, mortar on that. I put mortar on everything. And your platelets are like, all right, well, okay, we're here. So we're here, we're ready, and we don't have any clotting factors, but you've got your clotting factors that have formed clots with other things all over the place. You've used up all your clotting factors. Then what happens? You go to brush your teeth, all right? You make all these bricks, they're gone. You go to brush your teeth, tiny little something or a paper cup, tiny little thing, and all of a sudden you're bleeding out, bleeding out, bleeding out, bleeding out, bleeding out, bleeding out, bleeding out. I'm giving you a small example of what happens on the outside of the body, but that's happening on the inside of the body. So there's widespread clotting, all the clotting factors are used up. So now when I need to actually clot, I can't, so I have widespread bleeding. So you have a combination of both widespread clotting and bleeding at the same time. Now, if I have widespread clotting, I can give you an anticoagulant. If I have widespread bleeding, I can give you like some vitamin K or something to help you clot up some. How do I treat both at the same time? So these people, there's a high mortality once DIC happens. That's why pregnancy is very dangerous. So if you haven't been nice to your loved one that gave birth to you, even if they were a jerk, tell them thank you. Because they risk their life. Very, very dangerous. And if your kids have been mean to you and you gave natural birth to them, tell them, better thank me. Because I for real almost died. Ms. J said so. My question is, how do you treat this? What ends up happening is it's a delicate balance of both heparin and giving them clotting factors, exactly what they're missing. Remember, clotting factors can only be found in plasma. If it's not caught early enough, there's nothing that can be done. These mothers will bleed out.
Is this something that only happens in pregnant women?
No, that's just the most common. Oh yeah, it can happen with sepsis. Again, it's any sort of like when your body is so overwhelmed and stressed, under intense stress for so long, it can just activate and go, that's it, I'm done. It can, for sure. Matter of fact, I'm glad we figured this out. I had a patient, y'all may wanna look this up, it's like a Dr. House type of thing. I'm surprised we figured it out. We had a patient who got bit by a mosquito in India. Something called fever. It's only Indian mosquitoes. His brother had it, got a little sick, and he, was fine. He went over there, he came back here. He was in our ICU. In one shift, we gave him 11 blood products. I flat out had a dream. I had to pray. I didn't know what these people believed. I didn't care because this man was about to bleed from every orifice, and he was my patient before he started crashing. So I was able to talk to him like I'm able to talk to you. So I had to do something a little different. And we figured out that this certain rare cases, the Bengal fever, causes DIC. So once we figured out what it was, we knew how to move. He also had a GI bleed as a result. Everything was bleeding. Everything on the inside was bleeding out. So we had to scope him. We had to cauterize that way because we were just, it was coming out through his, whatever we were putting in was coming out of him. Interesting stuff. That was DIC. He got better, and the family was thankful. That was it.